Thank you so much, Professor Andrea. That was such a fantastic presentation that we're all really appreciative of, and keep the questions coming. So yeah, as Jorge says, I'll be presenting an integrated case study of one of my clients. It's very heavily disguised just because of the sensitive nature of this case. It's quite lengthy. I had 36 sessions with this client only on telehealth, and it's quite complex. There was a history of suicide attempts, homelessness, a lot of distrust of services and victimisation both in his homeland and here in Australia. And so what I'm going to present is a very much an overview and a representation of my trauma therapy with him. Let's call him Michael. I'll introduce you to Michael. Michael is a 42-year-old male. He's very educated at a master's level. He speaks more than 3 languages, and he's a Christian in a country where Christianity is the minority, and he is an asylum seeker. In terms of the experiences in his country of origin, Michael had multiple violent assaults perpetrated against him, and there's threats made against his family. There's a lot of survivor guilt, and he's fled to Australia 4 years ago to seek protection. Again, this is just a disguised genogram, but what I want to point out here is he's alone, the only one of his family here in Australia, and his brother has been killed tragically, and his parents are still alive. So this is, again, just a brief overview there. Because we conducted all our sessions on Zoom, these are some of the important things to notice, is that he's very courteous and polite. His mood is quite exasperated, however. He's in a lot of pain due to the extent of his severe physical injuries from the assaults. And it's also important to note there's no cognitive or perceptual disturbances with the client, but his thought processes are quite preoccupied with aspects of injustice and suffering. At STARTS, we'd like to use this model developed by Roach and Coelho to describe the complex interaction of challenges with which our clients present. So in terms of the client presents with his own trauma reactions. So at the top, we've got nightmares. There was some suicidal ideation, a lot of re-experiencing symptoms from PTSD, and poor or miscalibrated neuroception, which means he's having a lot of difficulties assessing for cues of danger and safety. Also, this occurs in the context of him trying to seek protection, and because of his homelessness and dire financial situation, he's also compromised in his health and nutrition as well. And this also occurs because he's a 42-year-old male, he's isolated, there's a loss of status and honour and unemployment that comes as well as expected in this stage of his life. And we can't ignore the recovery environment and perhaps the attitude of Australians towards immigration. And also we can't ignore international events that come. So there's ongoing conflict in his homeland and the intensity of that survivor guilt being separated from his family. At STARTS, we do have the benefit of referring our clients for EEGs. And my wonderful colleague Darius has given a very thorough explanation of his brain patterns, and I'm just doing a very brief summary here. But what we're seeing with Michael is that there's abnormal brain patterns, and his brain is incorrectly predicting the need to mobilize and defend. So it's stuck in threat mode, and it's a lot of difficulty maintaining balance within the brain and the body, and this can lead to fatigue and depletion over time. So we're also seeing a brain that's very fast and disorganized, and his mind and body is over alert. So we can imagine the impact of this on sleep. So part of the treatment aims is to establish a better brain and body connection and sleep hygiene practices as well. So I really appreciate what Professor Andrea has said, and we do know that in terms of evidence, IRT is at level 1, where, as we've heard, it does involve the modification of the dream content and then practicing and rehearsing a new desired outcome that's more positive. But it's my opinion as well, and the opinion of some of the authors down the bottom that I've listed, that there's quite conceptual similarities between EMDR and IRT. And we also know that EMDR is a level 1 treatment endorsed by the World Health Organization and NICE guidelines as well, like that, for the treatment of post-traumatic stress disorder. So the rationale for my treatment is that if EMDR can facilitate the distancing and reduce the emotionality and vividness of traumatic materials that's contained in the dreams and nightmares. It also has the installation of positive beliefs, and that promotes more adaptive processing about the trauma. And this can result in psychic changes to the experience and phenomenology of both the trauma and the nightmare itself. And there's further references there. And I'm very excited that recently there is a systematic review this year that says it's level 2 now, second line treatment to treat nightmares after IRT. So very fascinating, the mechanisms of EMDR. There's a number of hypotheses, but I'll just share the REM sleep hypotheses because it's so relevant. And we know that sleep is known to play a role in memory consolidation and emotional processing. And it's thought that like the ocular bilateral stimulation, so when the client views the therapist's fingers moving side to side, this can induce a REM sleep-like brain state and facilitate and integrate the nature of the traumatic memory and put it back into the semantic networks. So we believe, there's a hypothesis that the bilateral stimulation in EMDR mimics the same neural mechanisms in REM sleep. So that's something to keep in mind. And a little bit more on the bilateral stimulation is it also facilitates fear extinction and reparative neural networks. Lots of great research by Dan Siegel and other reputable therapists coming out there. And it doesn't have to be eye movements, although there is more evidence to suggest that this is more powerful. But we also do auditory and tactile stimulation, so a butterfly hug, tapping the knees, and things like that. So I love this graphic. It just summarizes everything because I can't give the full training and I'm not qualified to do that either. But in terms of like what EMDR does, before EMDR, the memory or the nightmare in this case is very vivid. The charge of it is very high, like it could be 8 out of 10. It feels like it's happening right now. And there's an associated negative belief, like I'm not good enough or something like that. And then following EMDR, it's more distant and desensitized, and the emotional charge can be decreased even to 0 out of 10. It feels like it's back in the past, and the way we feel and think about ourselves emerges with a new positive belief. For example, maybe the trauma's over and I am good enough, for example. So in 3 words, EMDR creates distancing, desensitization, and reprocessing, a little bit like this graphic here. I'm going to share a case conceptualization now because that's very important. It links our theory with our practice. This is quite wordy, lots going on here. So you'll get a copy of the slides, but this is adapted from Santos, who does EMDR case formulations. And it's important to note there's just many components here in the client's case. There's some bidirectional impacts of like how he sleeps and how he copes and the triggers. And there's also the intrusive experiences, negative cognitions. There's a lot there to take in, but I will also point out that we want to acknowledge resilience factors of the client Michael. And one of them is the capacity for meta-consciousness, which is being aware both of himself here now and in the past with the trauma. And strong attachment figures and good capacity to handle uncomfortable affect and somatic experiences. And I'll expand on those in a moment. I will, again, just give this slide at a glance. I'm not doing it justice at all, but there is a lot of empirical evidence to suggest that standard EMDR can be applicable for refugees and asylum seekers. It doesn't necessarily precipitate a decompensation. It doesn't cause dropout necessarily. It can be well tolerated, even more tolerated than other exposure studies. It's used in conflict zones. There's adaptations that have been developed, even Ukraine, Palestine, I believe, and even in refugee camps as well. So I know there'll be questions, please ask them, but there's research there. It reduces depression and pain, which is very relevant for my client as well. And there's many modifications and adaptations that can make it more tolerable and efficacious for very complex clients. And they're all listed there, and there's further that I'll explain. So the 8 phases of standard EMDR progress in such a way, but we know that our clientele and the complexity, sometimes treatment might look like this. So how did I go about working with Michael? I'll explain. So phase 1 and 2 involves history taking and preparation, and we want to gauge his readiness. And because of Michael's poverty and food insecurity, it necessitated like a referrals for low-cost meals and a wonderful nutritionist to support him, because how much is that going to impact his sleep and overall health? So that was essential and foundational. Also, because he's had such re-victimization within the system, and I may represent the system, the importance of safety and attunement is so critical. And we all know there's well-established research about the importance of healing attachment networks for refugees. We also want to help him with better neuroception so that he's not scanning and appraising everything for danger and misinterpreting that. Part of a very, very critical part of EMDR is the resource development. And this is where, with refugees and Michael, we want to inquire into his cultural or generational frames of reference, like people or places that he can incorporate to draw upon. And it's kind of like what Professor Andrea was saying there as well, like bring in bystanders, bring in people that act as what we call resources. This can promote safety in EMDR processing, and it helps them to flexibly shift back into their window of tolerance. So if there's too much hyperarousal and sympathetic activity, and it prevents them from drifting off into the dorsal vagal shutdown, they come back into their ventral vagal circuit with some of these practices. And we also can apply slow bilateral stimulation, butterfly hugging, the ocular movements in a slow way. That is theorized, and there's references there to strengthen and install these sensations. So again, because of my client's severe assault history and the impact on his sleep, we want him to feel the ability to cope with his uncomfortable emotions and body sensations. We do this prior to any exposure work, and there's references there again. So as well, before this activation of traumatic material, we want to assess his ability to cope with his pain. And there's many somatic exercises that I like to do. One of them is called pendulation, where you oscillate from a pained state into a resourced or a calm state, and show that they can flexibly shift between one state to the other. So that's part of the preparation work as well. And you can imagine how that would impact his before he goes to sleep. Because he was the victim of very violent assaults, there's a lot of adrenaline, anger, tension built up in his muscles. So things like isometric exercises where they can push very heavily against a wall or their own hands. Repatterning is another thing. So because he wasn't able to defend himself, this is completing the movements that were truncated in the assault. These are part of supporting the client safely process the pent-up angst and stress within their body, because obviously that's all critical for sleep and revisiting the traumatic nightmares. First, I will share a IRT script just briefly. This is a nightmare that was once a week, and the intensity is rated 5 out of 10, where 10 is most distressing. So he was saying, I'm in a game, there's demons that will come in and scare me. I try to throw stones at them. My mother and other women are trying to get them away, but they can't reach me. So we did some re-scripting with the client, and he was saying, I don't see demons. I see angels entering the room. They're embracing me. They're telling me I don't need to panic. I'm not alone, and I've got my mother and sisters here. The women can also be saints, like from his Christian faith. And so we're drawing upon his frames of reference. And the EMDR therapist in me reinforces this with bilateral tapping. It connects so it increases the felt sense of attachment and love with these sort of feminine archetype type of figures. And this has reported impact. This slide is just to show I'm doing my EMDR homework by listing all of the nightmares here I'm using, and I'm going to use the nightmares as the things to target. They've also got the components of the negative beliefs, positive beliefs, emotions, body sensations, and the distress. So I'm going to go through them one by one, how I actually process the nightmares. So this is one where he's told he can't return to Australia. On the left hand in that box, I've got the sort of original ratings just for reference. Excuse all the EMDR jargon, but yeah, essentially we start the processing for this nightmare. And I use the image of a wave because if you're familiar with this modality and any exposure work, it can feel like this insurmountable kind of anguish can be activated, and it can be quite intense. So he feels, as we start to process the nightmare, there's snapshots of the original assaults, and he feels a sense of moral injury. And then we feel the emergence of the face of his persecutor. So this is coming up in the session. We're on Zoom. How do we manage this? I'll explain. We've also got this crushing sense in his rib cage, and his physical injuries are exacerbated. He's got the urge to sort of like bite his hand and dig his nails into his hand. So it's very intense. I brought out some somatic interweaves to facilitate and isometric exercises to facilitate the processing, ones that I've described before, and to help him to come back into his window of tolerance. We also bring in resource figures, again, straight from the manual, straight from the client's point of reference. He wants to bring in the presence of Archangel Gabriel. So we bring this in and we reinforce this with slow bilateral stimulation, deep breathing, and this reinforces his sense of safety and connectedness. Then through the processes of the EMDR, the emergence of a new positive cognition from the Archangel says you're going to be okay. So we actually see this progresses, and Michael is actually able to confront his perpetrator, look him in the eyes and say, I'm not afraid of you. And the perpetrator actually, and this is Michael's words for word, the perpetrator doesn't seem so frightening now. And we have really good results. The distress comes right down to 1 or 2 out of 10. The belief I'm okay is really strengthened. And my client says to me, this is like a high dose prescription drug. It's hard to take, but he knows it's necessary. And I take that as evidence of very good affect and somatic tolerance. Another nightmare is more symbolic. It's like these sort of frightening images of like demons and ghosts. Things are touching me, like grotesque, ugly faces. They're very distressing. So we use this as the next target. He chooses to bring in the resource figure, his higher power being Jesus. And then there's this emergence of a positive belief, like I can handle this, I want to be strong. So when we hear this, we reinforce that with slow bilateral stimulation. And then the frightening figures vanish, the fear abates, and the emergence of a new positive cognition comes through. I'm capable to sleep normally. And the distress is down to 1 out of 10. So we take that as gold here. We're like, this client now is learning to feel capable to sleep. The next nightmare that I used, that I processed with EMDR, was about an immigration officer laughing at him. He feels, as we start the EMDR here, there's escalation in confronting the immigration officer. And again, we use a lot of somatic interweaves in this process to help, because there's just so much anguish and grief built up. I love Professor Andrea referred to this. I will as well. We talk about facilitating distancing in IRT, and it's straight from the manual of EMDR as well. So there's times when we want to pixelate the image to facilitate distancing, imagining it as a film strip of a movie as well. References are there. And then what we have emerged as we do these techniques in the intensity of the processing, the client says, I can learn to live with a refusal. And I don't know if people that work with asylum seekers, I do believe this is quite remarkable, a remarkable outcome to actually feel 5 out of 7, I can live with a refusal. I should give myself a break from thinking about this. What I really love with EMDR is it allows the brain to generate its own coping statements that I or even the client wouldn't be able to otherwise unless they're in this situation of undergoing the bilateral stimulation. So the client is getting this sense of like, I can live with this a bit longer. We get the distress down to 4 out of 10, and normally we'd like to get it down to 1 or 0, but because it's maybe unrealistic, we might be more ecologically valid to accept a sort of 4 out of 10 because of his visa situation. And then nightmare number 4 is, again, a similar one, being arrested in the airport. And here we do what we call a two-handed interweave. So we've got the dilemma of, do I care about this and deliberate over this issue of my visa, or do I leave it to God or Allah or whoever may be identified? So we've got this, and we locate the area of tension and disturbance in the body where that is felt, and we process that with EMDR. It's very effective. And from this place, the client was able to express a lot of verbal anguish about survivor guilt. And because of his brother being killed, this is in a very intense process, and we can bring in some cognitive interweaves, like from the manual of EMDR, like, what would your family say about the guilt? And then that can bring about some further resolution. That this was very effective as well, and he had that emergence of a belief, I'm strong and resistant. For future work, and this is so aligned with IRT, like the more I hear, I'm quite convinced, what we want to do is the third prong of EMDR that Shapiro has developed. It's often the one that's neglected, but it's very important, is we want to help Michael imagine a future template when he goes to bed. I'm capable of sleep. So we rehearse almost going to bed, and then we process any disturbance or distress, and we create the same thing. We do rehearse and we do imagery, and we sort of install that with bilateral stimulation as well. And finally, Michael has done really well with his work, and all credit to him. We think that his nightmare was probably estimated to be every single night, and now it's down to once a week. And bear in mind, he still has not got his visa resolved. So yeah, we also want to attribute wonderful work of our wonderful nutritionist Sayori, and it's quite a long treatment that he went in, and there's evidence to suggest that the magnitude of treatment effects is correlated with the duration, so it's quite long. He is able to implement his own rehearsal techniques and pair them with the bilateral stimulation before he goes to sleep. He's got a stronger ability to tolerate negative emotions and body sensations. And we've also got a more acceptance of his visa uncertainty. So I'd like to acknowledge the following people, and thank you so much for supporting the client and my presentation. And I would also leave some references here, some light reading if you're interested. But thank you very much for your time today.